This portion of CardioSource Video News is supported by the makers of Xarelto.
Welcome back. It's day 2 at ACC 12, and we're talking about late-breaking clinical trials. I've got my law firm of Block, Pappas, and DeMaria here, great panelists. So, Athena, tell me about something caught your interest this morning.
In the late-breaking clinical trials, there was a study that importantly looked at the outcomes of non-primary PCI in hospitals with and without on-site cardiac surgery. It was a very large trial, over 18,000 patients that were randomized to one of these two hospitals. Importantly, it was a non-inferiority trial, and there was no difference in major adverse events between the two trials as specified. What they did see was a slight difference when they looked at complete revascularization in the site that did not have on-site surgery. So more bare metal stents used, more visits to the cath lab to get complete revascularization. I think the other piece of it that's important is that the entry criteria were that they had to have qualified operators, they had to do at least 200 PCIs a year in these off-site places, and what was mentioned actually in the discussion afterwards, the majority of the operators worked at both hospitals. So it was a very useful study. Peter?
Well, we've waited a long time for the results of the Seaport trial, and this is a trial that was designed not to fail, right? The really high-risk patients were taken out of the trial, and they were referred to hospitals that had more experience. And the thing that is of interest to me, we all figured it would be a positive trial or a non-inferior trial. That's the way it ended up. I think this trial has done more to change the face of how interventional cardiology is practiced in the United States than anything else, because now many more small sites are set up outside of academic centers and tertiary referral centers where they're doing PCIs in patients who are relatively stable. That's not a judgment issue, it's just that's the fact. And so it has changed the face of how PCI is done, and I think going forward now with these data to support it, I think there will be more impetus to have more cath labs. Whether that's a good or bad thing is not always good. Now, the good news is that in some of these centers, there were docs who did the intervention at both places, right?
That's what she said.
Yeah.
I mean,
and so, it's hard to know exactly what the differences are, though there do seem to be some subtle differences that come out in the trial.
You have to ask yourself, why would you choose to have a PCI in an institution that didn't have surgery? I mean, is it not available? In San Diego, as I often joke, you can get a PCI in the bigger shopping centers. You don't have to drive more than 5 miles. So, I mean, it's not that it's not available. Is it better quality outside of a surgical program? Well, generally, the bigger programs have more oversight. So while I think you can do it, I think for the bulk of patients currently undergoing PCI in the United States, common sense would dictate if they have an equally available opportunity to go to an institution that has on-site surgery, probably better off doing it.
Well, I would argue that this shows that it's safe to go to a different site. And for some patients, it's convenience. And though it's a small number, I think in rural locations that they don't have that choice. You're right, in large cities, they should have choices. But I think patients can feel that at least safely they can choose where they want to go.
So, Tony, I thought you were crying over there. You're rubbing your eye like the comment. But tell me, there was another study that was kind of interesting. I know it caught your attention about pre-screening athletes.
Yeah, well,
it's a hot topic.
It's a really hot topic, Randy. We probably get a couple of manuscripts a month on this debate about how exactly athletes should be screened pre-participation. And of course, as you go up the ladder with more and more elite athletes, it becomes even more and more controversial. And it's been known for a long time that there's a significant incidence of false positive findings on electrocardiogram in both white and black athletes, but particularly in black athletes, this is very prevalent. Using some criteria, it can be up to 50% of individuals might have some abnormality on ECG. So the question is, should you do ECGs to begin with, or if you do them, should you always do an echo as well? And the interesting sidelight on this particular article was related to black athletes specifically, and they devised some new criteria for what really represented an abnormal electrocardiogram. That may be of some use, but one of the hot buttons here is that among some black athletes, they feel that this is an unfair examination that they're being subjected to, because there's going to be a high incidence of false positives that might ultimately disqualify them from participating in something that's very important.
So Athena, you know from the echo standpoint, obviously this has been talked about a long time.
Well, one of the arguments is, should we just jump ahead to echo? I mean, it's a much more costly thing to do. The Italians have argued for a long time that it's a much more useful and specific way to screen these athletes. You might argue that for all patients, particularly for elite athletes, they should be screened with echoes.
So Peter, if you're asked by a university or a high school team in Atlanta, what do you say?
Well, I think the problem is you have to screen them, because there are some athletes that drop on the field, and that's the ones you want to pick up. And I think the article also points out, or raises the question of, do we separate into ethnic groups different criteria for screening? And that makes it really tricky, because then you're talking about, well, this is not quite fair and so forth. Right. Not to mention, of course, the other side of this, which is cost, because if there is an abnormality that then needs to be pursued to make sure that the athlete can function on the field, it becomes costly. Echocardiograms, heart casts, God knows what, NMRs, and so the dollars really mount up quickly.
Yeah, unless you're using handheld echo, there's
good point.
There's the ability now to get these relatively small machines that give you a screen. They're not definitive, but they give you a screen, and that might be the answer. The problem is you need a really knowledgeable operator to work them.
Right.
So the take-home message on the pre-athlete screening with EKGs?
I think we don't know the answer. I think that there's still a lot out there that are positive, and what you do with that depends a lot on experience, how much you know about it, and then every once in a while you just have to go further, it seems to me.
Okay.
Yeah, I think so.
Well, so thank you all very much. Great panel discussion as always, and we thank you for watching, and we hope that you'll be watching more as we bring more information to you from ACC 12.